Hi, everybody, it's Dr. Eric Balkavage. We're back for another edition of the Thyroid Answers Podcast. We have another guest today. Her name is Louise Davies, and she is a professor of surgery, of otolaryngology. She's a head and neck surgeon, and we brought her on the podcast to have a discussion about thyroid cancer. It's a topic we haven't discussed yet, but I thought it would be a really good conversation to have on this podcast because so many people are having diagnosis of thyroid surgery or thyroid cancer, and we want to kind of figure out like what's going on and why is this occurring, and then what the appropriate strategies are. So, Louise, thank you so much for coming on the Thyroid Answers podcast. How are you today?
I'm good. Thanks for having me.
So I don't want to take too much of time out of your busy schedule, but there's a bunch of questions I'd like to ask. But let's probably just start with giving the listeners a little bit of your background, who you are, and why we should listen to you.
Well, I'm a professor of surgery, as you said. I work at Dartmouth College and actually for the Department of Veterans Affairs. So I take care of both our nation's veterans as well as other patients outside that. And I got into this area as a surgeon because at the beginning of my career, I was concerned sometimes that we were potentially overtreating some people. And one of the areas where this can arise and be a concern is actually in thyroid cancer. And I had a mentor and colleague who did a lot of work in this area. And so that's how we got started looking at thyroid cancer in particular. And I've been working in this area since then. So since about 2004, I've been doing research in this area, and I've looked at both areas around why we get this cancer, who gets it and why, how we treat it, and also the patient experience of what it's like to go through it.
So there are different types of thyroid cancer. So can you give us some background as to what are the different types of cancer that develop?
Sure. The different types of cancer that develop in the thyroid gland are mainly 5 different types. By far, the most common type is a type called papillary cancer, which is about 90% of cases these days in general. Great news, meaning it is the least likely of the thyroid cancer types to cause somebody's death. The others are higher risk cancers, and they are follicular type, medullary type, Hürthle cell type. And so those are the others that are high risk. They're much less rare, and the conversations around them are actually slightly different. So for most of what we're talking about today, I'll be referring to papillary thyroid cancer, which is the kind that 90% of people have, and the type that's lowest risk.
So are the numbers increasing? It seems like there's more people getting diagnosed over time. Is it accurate that we're just getting more biliary thyroid cancer? Is it something about how we diagnose it? What's going on? Because I've looked at papers and looked at statistics, even read your paper, and you're like, what is going on here? Because definitely we see more and more people getting diagnosed with hypothyroidism. And we can have that's a whole different discussion. You said like, hey, that's maybe not my wheelhouse, maybe as much. But why does it seem like the incidence is increasing?
That's a great question about why thyroid cancer incidence might be going up. And you are absolutely correct that the incidence of thyroid cancer has increased 3 to 4-fold over the past 30 years or so. And this is the area where I first started doing my research, and we published about this as early as 2006, and then have been following the trends since then. And we are diagnosing many more thyroid cancers. The most common type of cancer that's being found in this increased group are the small papillary cancers. So the ones that are 2 centimeters or less, and 2 centimeters is like 2/3 of an inch. So small ones that are usually too small to feel. And those are also, interestingly, these small ones are also ones that we actually know that people sometimes have and never even know about it. So let me stop there for a minute to see if you have any questions, and then I could explain to you how we know that people have it and never know about it, right? Because that feels a little bit of a tautology there. But any
Yeah.
questions about what I just said?
No, I think I'm good. You can keep going.
Yeah. So when we look at people who've died of other causes, so they call these autopsy studies, where you are able to take people who, for instance, died in a car accident or some other natural cause, and you look at the thyroid glands of those people who never had a known thyroid problem in their life, you find that about 10% of people have a very small thyroid cancer, a papillary type in general, although occasionally you see some of the other types. And so we know there's what we call this big reservoir of cancer out there in people who may never have known that they had it unless we uncover it. The same thing is true in prostate cancer and in a few other cancers. And so if people are familiar with the issues around prostate cancer, it's very similar to thyroid cancer. And so over the past 30 years or so, we've been doing many more ultrasound exams than we ever used to do before. And we're also doing many more CT scans, special imaging studies that take pictures in a cross-sectional way, X-rays. And as we do more imaging studies, MRIs, all these things, like, and you get an MRI of your neck, or you get a CT scan of your chest, say after you get in again, for lack of a better example, a car accident, or you fall off your bike and you get an X-ray and somebody sees something that looks like your thyroid might have a little nodule or something that you never knew about, but then all of a sudden it's been uncovered on an imaging study. And so then we check it out because, sometimes it is a cancer that we're going to be worried about and want to do something about, but we also know there's this big reservoir of cancers that are quite small that are probably not going to become active. And that's really been the crux of the issue.
We're seeing them incidentally, and then coming in and investigating, say, hey, we have these abnormal cells. Now we need to do something about it. When maybe we really don't. I've looked at the prostate story as well. And if you're a male over 60, at some point, you're probably going to have abnormal cells.
That's right.
And maybe the same thing is going on with the thyroid tissue. Aren't we always have some level of abnormal cell development, and part of the immune system, like the natural killer cells, isn't it their job to kind of circulate around and look for these abnormal cells and just get rid of them?
I mean, I would think it is. I'm not an expert in natural killer cell function, but when we've done studies so one of the things that they've done with these very small thyroid cancers is, rather than remove them, this practice started in Japan, but they actually monitor the smallest ones, meaning they check them with ultrasound over time and see if they grow or change and need to come out. But many of the cancers don't grow, but some of them get smaller, right? And so that implies that perhaps is something going on. I don't know whether it's natural killer T cell. We don't really know what it is. But yeah, so not all cancers grow. Not all of them get bigger. Sometimes these thyroid ones, they sometimes even get smaller.
So is it because we have a lot more hypothyroid diagnosis, and we know that there's two primary drivers of hypothyroidism? One is iodine deficiency, the other one is thyroiditis. Is some of what we see possibly even just a change in from a cellular morphology standpoint, maybe secondary to some of the thyroiditis that's going on?
That's a really good question about whether thyroiditis is contributing to an increase in the incidence of thyroid cancer. So we know that, well, first of all, for the other part, for the iodine, we know that if you have more or less iodine in your diet, the risks of follicular cancer and papillary thyroid cancer sort of flip back and forth. The thyroiditis question, I feel like, is more of an open one. You've probably found the same in your own investigations. There are some studies that seem to show a relationship between the development of, not development of, but an association between people being diagnosed with papillary thyroid cancer having also had thyroiditis. But then there have been other studies that have said, no, there isn't a relationship. And I'm actually not sure which way it goes. And it may be that for some people it is related and for others it's not, quite frankly, right?
Well, I think that's part of the challenge, right? When we think about what drives thyroiditis, there's so many potential issues. And what we like to do is have nice packages, right? Like this is caused by X in everybody. And especially in thyroid physiology, and especially in the functional medicine space, it's nice to have these, protocols. Like everybody has a gluten issue. Everybody has it. Like these aren't. It's so far from the reality. I typically look at what's going on with thyroid physiology, usually not as the primary problem. I'm usually considering this is a person who's got a chronic inflammatory process going on, driving this kind of cell stress, cell danger response. That's reducing T4 to T3 conversion. Those cells in danger releasing DAMPs and PAMPs to activate the immune system and say, hey, I'm the tissue that's damaged. Get these molecules. This is the thing that's creating challenge. And I don't know, and this might be in your wheelhouse, maybe not, but what I've read is that the thyroid cells actually have pattern recognition receptors for those DAMPs and PAMPs, and that when those DAMPs and PAMPs bind to the thyroid cells, they actually induce an immune-like response initially and create damage to the thyroid cells themselves. And then it's the thyroid cells that then release more inflammatory signaling molecules, and that results in the T cells infiltrating into the tissue. And so to me, I look at that and I go, maybe this whole thing that we're dealing with is not like, okay, my immune system woke up one day and it doesn't pay attention. It doesn't realize that that's my thyroid tissue anymore. And instead, it's an adaptive response to slow down physiology and ramp up cell defense. Because if we look at what's happening in peripheral cells under stress, they're stiffening their cell membranes, they're reducing transport of nutrients, they're actively down-regulating T4 to T3 conversion to limit the amount of oxidative stress. So I just kind of think like, is it really that many people in the world that they woke up one day and their thyroid glands in their immune system just have this physiologic mismatch all of a sudden? Or is there something bigger going on, but it's not this neat, like, here's the problem, and this always causes the same diagnosis? Does that make any sense to you at all?
That makes sense to me. I think what makes sense to me is that some people who have a thyroiditis picture are experiencing what you describe, and some people may have another mechanism or some other cause of it. And teasing that out is really the job of the basic scientists who spend their time analyzing these things in the lab.
So we talk about the papillary cancer getting diagnosed more, probably incidental. But once somebody gets diagnosed, now what's happening? Because it seems like there's more people getting, I don't know, I've been doing this almost 3 decades now, and it seems like there's more people showing up at my office who've already had a thyroidectomy or radioactive iodine treatment. And I don't remember this many being done. So what's the scenario of, okay, you got this nodule, is it doing something, is it not, should we take it out? How does that typically work from a medical perspective?
That's a good question. So I think the right place to start is how does a nodule even get found? So we talked at the beginning about how they're often found on imaging studies, but another way that I didn't mention are 2 ways. One, you go to the doctor and for a checkup or for some unrelated complaint, and they feel the neck, they wonder, do I feel a thyroid nodule? And they order an ultrasound and a nodule is found. It may or may not correlate with what was felt. but that's one way it can be found. The other thing is sometimes when people show up with things like, I'm tired at the doctor, or I'm losing my hair, or I feel anxious, can you check my thyroid? An ultrasound gets ordered. And actually, that's not the right first test, as you know. But sometimes it gets ordered along with all the other thyroid tests and general workup that you would do for someone who's just not feeling right. And so I would urge people to reserve a thyroid ultrasound for if it's really indicated, right? Because once you find a nodule, it's hard to stop the analysis of that and then the workup of that, when in fact your problem may not really have had anything to do with needing a thyroid ultrasound. But let's start there. So once a nodule is found, the first decision that has to be made is, are we going to do a biopsy or not? Interestingly, when I've talked with my colleagues, I think in the past, many of us told patients that, okay, you have a thyroid nodule, we should do a biopsy, but maybe we didn't do quite as complete a job of explaining what happens once you do the biopsy and what are the downstream events after that. So I think it's always helpful for people to know what to expect if a biopsy is recommended, and to understand that that's actually a branch point in the decision making where they could choose to biopsy it or not biopsy it. And they might work with their doctor to decide, is this high enough suspicious that we actually need to do a biopsy, or could we actually just see if it actually changes over time? Because if it's a smallish nodule and it's not changing over time, it doesn't actually really matter, necessarily what it looks like when you take a few cells out of it, if it's stable. But commonly when thyroid nodules get to a certain size, we often say, okay, this is a size above which biopsy is recommended, because if it is a cancer, then we would probably want to remove it. And so you get a biopsy result back, and that biopsy result can actually be anywhere from, we use this system called the Bethesda rating system, which is named for where the National Institutes of Health is located. And you get a score back from anywhere from 1 to 6. And 1 actually means you didn't get enough cells, so you didn't get a diagnosis at all. A 2 means it's benign. A 3 or a 4 means there's some abnormal cells, but you can't really tell whether it's cancer or not. And a 5 or a 6 suggests that it's probably cancer. And of course, those then lead you down different pathways that we could talk about next. But that's sort of how you get to that, at least that important branch point.
So then let's talk about the next steps. What might be the next steps?
Yeah, so let's actually work first with if a biopsy result comes back and it's a 5 or a 6 and the nodule is small. Like these days, we actually don't recommend that nodules that are smaller than a centimeter get biopsied at all, but sometimes for whatever reason, a biopsy is done. And if that's the case, and it turns out that it looks like it's cancerous, one of the options actually is what we call active surveillance, which is where you don't remove it because it might be one of those ones that we talked about at the beginning where it's actually been present a long time. It might stay there your whole life and never change. So rather than go in and take out a piece of somebody's thyroid gland, which creates all kinds of new problems and risks and side effects, leave it, do an ultrasound. The way we do it in the United States is an ultrasound every 6 months for a couple of years, then once a year after that, until we feel confident that it's not changing. And just watch it. And if it doesn't change and nothing else changes in your health factors, or you don't change your mind, then you don't need to take it out or do anything. Active surveillance doesn't mean that you don't do something if it changes, right? If it starts to look like it's growing, if there's a health concern, unfortunately, like occasionally people, like if you need a kidney transplant, a lot of times they'll be like, nope, that thyroid nodule's got to come out before we'll do your kidney transplant, for instance, things like that. And you say, okay, so then we remove that half of your thyroid gland. But the
tendency would be to take the nodule or the full half of the gland.
Yeah, so in general, we take out the half of the gland. We don't usually take out just the nodule for various reasons. I mean, it's oftentimes hard to do, but it's it's not in the right location to really be able to just take out a nodule. The thyroid is so vascular, and you always want to take care with the nerves in the area. So that's the usual. So active surveillance these days, even if it's like up to 1.5 centimeters or so, they'll even monitor those ones as well. But then the options after that are taking out half the thyroid gland. And these days we recommend that if the nodule's less than 4 centimeters, most people probably only need half their thyroid gland removed. It's only if it's bigger than 4 centimeters, or, for instance, if a person has lymph nodes that look like they're involved and has a cancer, then you take out the whole thyroid gland for other reasons. So that's sort of those steps in that part of the decision making.
So there is thermography is out there. I'm not sure how much you utilize it, but is that utilized at all as a tool to see if there's a change in the heat signature?
Thermography. I'm not familiar with that. Are they using it with ultrasound, or you aren't talking about like iodine 131 scans or like anything not the hot cold nodule thing?
No, they're not putting any dye in. They're just taking a heat signature of the tissue. And so they do that. And let's say initially somebody goes in and they'll do either a regional thing over the thyroid, or they'll do a full body, and then they'll see hot or cold signature, looking for differences from side to side, any hot points, any cold points. And then typically what somebody will do is go back and get a rescan not too long afterwards to say, okay, like, did anything change significantly? Like, because there could be a lot of things that throw it off. But if you see that same, like if it was a thyroid gland, if you saw the same heat signature a couple months later, it's the same size, maybe same thing, maybe not something that needs to be checked out, but you keep following up. And if that heat signature changed, or that signature got bigger, more significant, then yeah, now you're going, maybe this is something we need to investigate a little bit further. So I think a lot of that thermography kind of started around with breast type stuff, because what are we doing to women, right? We're squashing their breasts between two pieces of plastic and then radiating them, which both potentially create a little bit of damage to the tissue, to find out if there's damage to the tissue. So thermography is a nice way to potentially do a less aggressive screening process without creating any damage. Now, it's not wouldn't be foolproof, and you would want to do that in maybe a combination of things, but instead of radiating a tissue every year to see if there's a problem, see if there's tissue change or damage or growth, thermography might be a tool. So they can look for a cold signature, a hot heat signature, but really any change in that pattern from session to session, like that would throw somebody into going, hey, why is that? This was not a big heat signature before. What is going on? We're not radiating a lot of thyroids, right? We're doing ultrasound, which is
right. Yeah. So I mean, I'm not a breast cancer expert, but I can see how somebody might want to use thermography because they worry about the X-ray dose from mammography, although it's an extremely low dose, but I get that. But yeah, we have not used it in the thyroid, probably because it's ultrasound and it doesn't have a cumulative radiation effect. So we use ultrasound, which is, I think it's good that you bring it up. So for people to understand that ultrasound is safe, it's not radiation. So you're not radiating your thyroid when you do an ultrasound to monitor a nodule there. And also you can use it to monitor lymph nodes and that kind of thing as well.
So if we take out a thyroid gland, let's say we monitor, we manage, we see that this nodule starting to change and develop, is there something, and this may not be where you're involved yet, but if somebody gets a diagnosis of having a nodule, let's say it's a small one, we're in kind of a watch and see what happens. We really don't know what's potentially driving it, but are there typical recommendations just from a general health standpoint of things that somebody needs to consider? Like, hey, we don't know exactly what might be driving this abnormal tissue, but here's the things that you should be considering from a general health support to prevent this from maybe getting worse.
That's an interesting question of whether we actually have lifestyle recommendations for people with either thyroid cancers or nodules that are under surveillance. Is that what you're asking about?
Yeah, just like,
Yeah.
hey, you got prediabetes, like here's things you should do, right? Hey, here's a nodule. It's probably maybe nothing, but these are things that we find. And maybe like people with these conditions, people who do these things have a greater incidence of developing cancer, thyroid cancer. Do we know? Do we provide any advice?
Yeah, no, that's I'm a little embarrassed to say we don't have enough knowledge to be able to say what lifestyle factors might help. We know the risk factors for thyroid cancer there's a rare familial syndromes where you can have it as an inherited disease and radiation exposure at a young age. But I think that's where people like you in functional medicine can come in to make recommendations, because from an allopathic standpoint, we don't actually have much to offer about, like, here's the diet you should have, here's how much exercise you should or should not have, because we've looked at it from more that biological perspective, and all we really know is radiation causes thyroid cancer and certain genetic polymorphisms that people have in their family or that they inherited. Yeah.
Do you know if the use of thyroid medication, which is also on the rise? I mean, I think it is decade after decade, year after year, it's one of the most prescribed medications. I had Joel Corey. He is a clinical chemist out of Yale. I had him on the podcast. I don't know if you know his name at all, but we had a discussion because he's saying, based on the literature, and I tend to agree with him, and I think the functional medicine community, integrated community is to blame for a lot of the overuse of medication, which doesn't make probably my peers like that, what I'm saying. But we had a discussion because he said, I think it's close to 60 to 90% of the people on thyroid medication are over medicated. And I tend to agree with him. And from our perspective in functional medicine, like, everybody's trying to optimize somebody's labs. And I'm like, what are you optimizing? Like, if the values are out of range, that doesn't mean that the body isn't optimal. That may be the appropriate response. It's like saying, hey, we've got to get rid of this fever because that's abnormal. Well, the fever is the body's adaptive response. And I think, as we talked before, I think when we see somebody with reduced T4 to T3 conversion, if we see like normal T3 and a low normal T4 and a low T3, sometimes a TSH that's a little bit higher, we don't need to jump into medicate those people. We need to be saying, hey, let's take a look at what's going on with their surroundings, their environment. Is this broken physiology, or is this an allostatic change in their physiology to adapt to some type of excessive stress? And so if we intervene, that may actually create more issue. So do you know if there's have you seen that, hey, because of this increase in people on thyroid medication, maybe appropriately, maybe inappropriately, does that lead to potentially more cases of cancer down the road?
That's interesting. So you're asking me, does giving people thyroid medicine make them at higher risk of developing thyroid cancer?
Yeah.
Not that I know of. That's a really interesting hypothesis. So we actually have used thyroid hormone and made sure that when people have a higher risk form of thyroid cancer, that we give them enough thyroid hormone that we keep the brain from sending out messages, so we keep the TSH tamped down, because we believe that will actually help prevent regrowth of cancer, right? if we don't have that stimulation of messaging going out from the brain, the thyroid stimulating hormone. So it doesn't, on the face of it, it doesn't make sense to me that giving thyroid hormone would cause cancer when actually we use it to make sure that people who have a history of thyroid cancer have their risk lowered as much as possible for recurrence or growth of their cancer. I thought that you were actually going to ask me about something else that's very controversial with thyroid levels, which is what is the definition of normal, which I'm sure you talk about a lot here, because the general laboratory values of what's normal have traditionally gone up to like 4.5 or 5, but people have argued that most people's range or quote, they feel right when it's like closer down, less than 3. And so there's this debate about at what point do you offer somebody extra, essentially what would be potentially extra thyroid hormone to supplement them.
Yeah, well, I'll come back to that one. Okay, but here's why I ask, and I think it's while the thyroid gland itself is making thyroid hormone, right?
Yeah.
We do know that thyroid hormone, especially T4, can bind to integrin receptors on the outside of cells and cause them to replicate, right? So knowing that and knowing that that can happen, and we talked before, I kind of look at things from that cell danger response, and I'm a cell in danger. I'm not bringing more T4 in to increase metabolism, I'm actually reducing metabolism. Now it changes between cell type and mechanism, what's going on, but there's a general decrease in T4 to T3 conversion under inflammatory conditions, at least peripherally. Hypothalamus might get upregulated, but if T4 can do that, and if you think about that hypothesis that hypothyroidism could be a protective response against abnormal cell growth, then you would say, man, maybe these people that we're putting on thyroid medication, are we potentially putting them at risk of developing more cancers down the line? That was a hypothesis. So I'll jump in there. So I thought I said nobody to my friend Kelly Halderman, who's an MD. We wrote a book called The Thyroid Debacle. And as I'm writing this book, and I'm like, this has been my thought process. I'm like, Kelly, nobody will ever do a paper that looks at the increased incidence of cancer in people on thyroid medication. And sure enough, 2019, somebody did a meta-analysis. And yes, the incidence of a whole bunch of types of cancer are increased in people on thyroid medication 5 to 10 years out. There's a few that are better. And I think the ones when you're talking about at the gland itself, because the thyroid gland isn't really pulling in a lot of thyroid hormone itself to drive it. So it's probably less of an issue at the gland. But I didn't know in your situation, you're like, yeah, these people are all on medication or they're already on thyroid medication, or if it's more of that incidental thing. But peripherally, yeah, it seems like the mechanism, and there's been more papers coming out now in the last couple years. I've turned into like a paper geek, right? Reading too many of these things on my my Mendeley's overloaded with papers, but talking about how hypothyroidism is a protective response against cancer. So it's really interesting, which is one of the reasons I'm really concerned about intervening too early. So that's where I was kind of coming at, like, when these people are coming in, are they more incidental, or these people who are already on some form of thyroid replacement therapy? And you may not know because you may not have really even considered it.
Well, I think, when you asked me the question before, I was thinking about, would putting someone on thyroid hormone increase the risk of thyroid cancer? And so, that doesn't make sense to me. But I think your question about could it put you at risk for other cancers, and it sounds like that's where somebody did a meta-analysis that you were pointing to. Mm-hmm. That's very interesting to me, because I mean, I could see how you might go down that pathway. Now, I think a a careful thing is what we would want to look for next is a mechanism. And it sounds like, I'm not an expert, but it sounds like that's at least been partially elucidated, right? Because you can have two things that are true and unrelated, like,
Yeah.
Wearing an underwire bra is associated with breast cancer. Well, also like having breast is
Causation or
associated,
correlation, right?
right,
Yeah.
right. So causation versus correlation. So what you'd look for is that mechanism between having extra thyroid hormone around and then the development of these other cancers. So that is interesting.
Yeah. From what I've read, it's that AVB3, integrin AVB3 receptor on the outside of the cell, which is where that can occur. Less likely from T3 because you'd have to have a lot more T3 to do it, but it could be that extra T4 in circulation, not getting into the cell, binding to those receptors and causing those cells to replicate. But let's move on to the other point that you brought up, which I thought was a good point and one that Joe and I spent a bunch of time with, because in the functional medicine space, everybody's talking about the optimal range of TSH. And I think a lot of that's BS, okay? I think lab ranges are meant to be, to move, right? The lab value is not the problem. The lab value tells us a story. If TSH goes up, that may be because the thyroid gland needs to pull more iodine in. It needs to make more T4. Maybe there's a reduced T4 to T3 conversion to periphery, and the thyroid gland is kicking in some more help, making more T3 instead of T4 to compensate for the reduction. So that's my opinion, but I'd love to hear your opinion. You may say you're totally wrong. The optimal range should be between 1 and 2.
So, again, like I'm not an expert in this area, but I recently was actually an invited speaker at a conference in Denmark. But one of the other speakers was talking about inappropriate treatment with levothyroxine and the fact that there was increased mortality associated with giving people levothyroxine, especially older people who naturally have a higher TSH, and that those people who were not treated and had a higher TSH had a longer lifespan. So than those who were treated. So it's definitely something that we need to be looking into more because you don't want to harm people as they're aging, right? You want to support their bodies to function as well as they can. And so we're talking about people, what I would call, so the old, so especially people in their 70s and 80s. We could be causing real harm.
Yeah. So for the listener, I think it's important because you'll hear, especially in the functional medicine space. I mean, if somebody feels good and function good, and they're, I might say, yeah, if you're TSH between 1 and 2, that's great. But I don't think we should be treating somebody because their TSH is 2.67, even if you have some hypothyroid signs and symptoms. That's where we need to look at the rest of the labs, look not just the thyroid panel, inflammatory markers, blood glucose markers, lipid markers. Look for not just an indication of a slightly elevated TSH and a slightly elevated drop T3. There are so many things that can influence it. And I think we have a tendency, especially in the functional and integrative space, to intervene way too early with thyroid medication. So I don't want to put you on the spot because I know that that's not your wheelhouse. So I will save that part of it. So we've got more cancers. We think that maybe we're finding these incidentally, but when we do find them and we do a thyroidectomy or radioactive, is the treatment typically just removal? Is the treatment typically removal and radioactive treatment? Is it a combination of both? What's the typical treatment strategy?
So the typical treatment strategy for thyroid cancer, and so I'm speaking here broadly about papillary thyroid cancer, although it's mostly true for follicular as well. But usually, if it's a lower risk or even intermediate risk cancer, just removing the cancer is enough. No further treatment is needed, and then they can go on from there and monitor. If it's a higher risk cancer, meaning there were lots of lymph nodes that were involved, the cancer looked like it was spreading outside the thyroid gland directly, like into the nearby muscles or tissues, or the type of cancer and its characteristics, I should say subtype, is problematic, such as a type called tall cell, which means the cells look a certain way, or if there's evidence that lots of blood vessels or nerves were invaded, then you might consider removing the other half of the thyroid gland if you only took out half and doing radioactive iodine. We used to do that much more in decades in past, and then it was recognized that that probably was not needed. So we use it much less frequently now, but it may be why you and your colleagues, 10 years ago, and if you get people in your practice who were treated long ago, had a seemingly tiny cancer that got radioactive iodine. It used to be everybody got it, everybody got a total thyroidectomy, everybody got radioactive iodine. We're much more nuanced in treatment approaches now.
Can that other half that's removed of the thyroid gland, can that grow back?
No, once you take out somebody's thyroid gland, it does not grow back. If you take out just half, then oftentimes people can get by with just that half and make enough native thyroid hormone to go on and continue a normal life without taking replacement pills. But depending on what you define as normal function, about a third of people will miss that half of the thyroid gland that they don't have anymore and will need replacement. But if you leave half the thyroid gland, that's all that's left. It doesn't grow back.
Okay. And so the other thing, and I've read a bit about this, is the Hürthle cells. Can you describe what the Hürthle cells are, the significance of those? I had read, I think, a paper or two that the doctor who discovered those cells initially said, hey, maybe these were cancer, or then maybe said maybe these aren't cancer. So what's Hürthle cells? What's Hürthle cell cancer? Are Hürthle cells always develop into cancer? Can you cover that a little bit?
Yeah, so it's a little bit of a misnomer, but Hürthle cells are actually normal cells, but they're what are called oxyphilic. And it just has to do with how they look under the microscope when you look at them. And there actually can be seen in both cancerous and non-cancerous nodules in the thyroid gland. So if you get a biopsy report back, of course, all of our pathology reports are released to patients immediately, and you get your report, let's say, and you have it and it says, oh, it's a Hürthle cell aspirate, it doesn't necessarily mean that it's cancerous. The only way to really know for sure if that's a cancer would be to then remove it, or sometimes we can tell with some molecular testing that can be done on some of the aspirates. But yes, the other thing to know is that we used to classify Hürthle cell cancers as a subtype of follicular cancers. And then Ian Ganley and his group at Memorial Sloan Kettering figured out that actually it had Hürthle cell cancers were unique and actually should be separated from follicular cancers as a separate type. And so now we do consider Hürthle cell cancers to be their own type of cancer when it's an actual cancer. And we actually, we stopped calling it Hürthle cell cancer. We now call it oncocytic cancer, which at the top of the hour, I should have said, not Hürthle cell cancer, but oncocytic cancer. So we're all trying to retrain ourselves to stop calling it that.
So but in the past, people, they would see those cells and think, all right, the person's got cancer, even though potentially the cells were there. Because I thought I read a paper where I don't remember who the doctor was that named the cell, but I think I saw a follow-up paper where he was saying, hey, we got to stop taking stop doing so many of these thyroidectomies, these aren't always cancer cells, as you were kind of
Yeah.
explaining.
Yes, and I think it did take us a while to realize that, but you are absolutely correct that when you get a needle biopsy result back and it has what are called Hürthle cells in it, it does not necessarily mean that it's cancer. And so you shouldn't use the presence of those kinds of cells in a biopsy result as a reason to take it out. You would look at other characteristics of that needle biopsy sample to make that decision.
Right. And I got one more question. I know I want to kind of make sure you get off to lunch, but I have one more specific question I want to ask, and then I'll let you kind of give whatever final commentary you think might be really important to the discussion. But, and if you don't know the answer to this or don't have an opinion, obviously just let me know. But we're using a lot of these new drugs that everybody's wanting to take for weight loss and dance around and sing about lowering their hemoglobin A1C. And I've seen more and more papers discussing these GLP-1 agonists and the potential tied to thyroid cancer. Now, guarantee it looks like all of the studies are animal studies at this point, but have you heard this? Have you seen anything on it? What's your take on it?
This is a good question, and this is an area that I think we're really still trying to understand. I've seen studies going in both directions that yes, there's an increased risk of thyroid cancer, and no, there is not. There does seem to be a risk for people who have a history of medullary thyroid cancer. You probably wouldn't want to use these drugs, but I have not seen that the data are really 100% yet that it causes papillary thyroid cancer. And I think we just need to watch because, right, we have this issue of this reservoir of small cancers. And so if you start monitoring people who are taking these drugs, we are going to find small papillary cancers. I would be concerned, though, if we started seeing more medullary cancers develop, if we started seeing larger aggressive papillary thyroid cancers, because that would suggest that it's not this reservoir of stuff that's just out there in people. So I think that's what we'll need to be watching for.
Yeah, I think it's a concern. It's definitely a concern when you see that stuff come out, and this is like the new hot thing everybody wants. Unfortunately, it's not without side effects within the GI tract. And if you're doing those medications many times, if that is helping, you probably already have gut dysbiosis and the lack of GLP-1 production. Maybe we should be fixing and addressing the gut dysbiosis that's going on, that's not allowing for appropriate GLP-1 relief from the individual to begin with. But when I started seeing those things show up, I was like, that's probably not a good path for us to be going down, because these things the medications are, well, can't get them fast enough to start trying to lose weight. So is there anything you think on this topic that we probably should cover before I let you go off to lunch?
I think that one thing we need to cover is just that reminder that if someone finds a thyroid nodule on you, a good place to start is just to realize that when somebody finds a thyroid nodule in your thyroid, it's actually okay to stop and have a conversation about, what does the thyroid nodule look like? Does it look like a high risk one? Do we need to do a biopsy? What will happen if we do a biopsy? And just to realize that people have control over that, and that it's okay to go slowly and ask questions so that you don't feel like you went down some pathway where, like, oh my gosh, I showed up because I was feeling tired to my doctor. Someone found a nodule. They haven't actually fixed my other problems, but now we've got this nodule that we're working up, and making sure that we don't get carried off down a path to work up something that may not actually be solving the problem that we're having.
Yeah, I think I saw, and I think you alluded to this earlier, but I think I read a paper where it said like if you took, you know, 90% of the people are going to develop a nodule over their lifetime. And I was like, huh. Yeah, I mean,
That's right.
that's a lot of
That's right.
people, right?
So
Right?
yes, so the way the classic paper is this paper from the 1950s, and the way it was hard for me to remember it, and so I said I made a little moniker for myself, and then I've seen other people say it too. But I basically try to remember by age 50, half of us have nodules, and by age 90, all of us have nodules, right? So it's like that. If you're 50, half of you, and then as you get older. So you can't really get out of this lifetime without probably having at least one nodule.
Yeah. And so I guess the last piece to add to that is, hey, once you have it, take your time, kind of get it evaluated, get some opinions. But is there some of these things may not change? The nodules may not move, but obviously people get concerned, like how aggressive this is going to happen, like how quickly do they need to move? So is there a form of cancer that somebody might get diagnosed with where the decision needs to be made like now, or are most of these slow progressing, slow moving things that the nodule may not progress? Some of these cancers may not be, they're super slow, so you've got time to make decisions, where some of them are just like, hey, once you have this, you got to get this taken care of right away because it could spread, metastasize, create other issues.
It's good to make that distinction. There's definitely a difference between the nodule that you never even knew about until somebody told you they saw it on an imaging study, and that's completely different from a nodule that you feel yourself, that you can feel changing and growing in your neck, something that feels different that's growing. Those, without a doubt, should get checked out and move promptly on. So that's absolutely a perfect distinction to make. So new lumps and masses in the neck or in the region of the thyroid, which is right above your collarbones, right over your windpipe, especially ones that are growing and changing or that feel like they're pulling or tethering or tight. All of those are signs that you should go get checked out right away and take action.
Awesome. Well, I thank you for coming on the Thyroid Answers podcast. And we said we'd try and get you done a little bit shorter time frame. I appreciate you coming on. I think we got a lot of information out of you. Is there, if there's nothing else you need to add to this conversation, I will let you go. And once again, I appreciate you coming on the podcast.
Well, thank you so much for having me. It's fascinating to hear this other viewpoint, and I really appreciate the naturalistic approach and holistic approach, because I think there's a lot of value in just taking care not to overtreat, and I appreciate what you're doing out there. So thank you for having me and for doing the work you're doing.
You got it. All right, everybody. Listen to this a couple times, share it with friends and family, and we'll be back in another week or two with another episode of the Thyroid Answers podcast.